Kia ora tātou again. The race to lunch. We've got a really interesting topic which we're going to discuss, localism and Indigenous health. And I'm going to be assisted today by Tom Irvine, the CEO at Ngāti Whātua Whaimaya, and Dr. Eric Crampton from the New Zealand Initiative. I'll just draw your attention to this publication here because it really sums up some of the things that I think Eric and Tom are going to talk about. But first of all, let me introduce Tom to you. Tom's the CEO at Ngāti Whātua Whaimaya. He's got a wealth of commercial experience, he's got a wealth of community experience, and he's got a wealth of cultural experience. And so before he had the role at Ngāti Whātua, he was actually the Deputy Director at the Auckland Art Gallery. I know he's got a real passion for art and culture. He's also got a passion for cooking. I've been very successful with one of his recipes, and I know he made curry last night, so I believe that was very good. He'd been cooking for a day, apparently. So those of you who know Tom, you know he's an influencer, and he really does personify. If you remember back to that proverb that I quoted this morning, we talk about people, place, and purpose. And he tangata, he te kawa me kaupapa, that really sums Tom up and his philosophy on life. So I'll get Tom to talk after Eric in just a moment. So Eric Crampton, those of you who know the initiative well know he's the chief economist at the initiative. He previously had an impressive career as a senior lecturer in economics, but he's also a media columnist, and apparently there's a photo of him in a bath of milk at Te Papa. So he's obviously really into media. Eric's worked on a lot of policy areas. You've probably seen some of his articles. He's on radio, he's in print, and he really is an authority on quite a range of areas: freshwater management, earthquake preparedness, local government policy, tax, and of course health. And so it was a real pleasure earlier in the year, although we've known both Tom and Eric for a while, to join them on a study tour to Canada, to look at what other people do in this area of Indigenous health. What can we learn, and what can we learn not to do as much as what to do? So I'm going to ask Eric to speak briefly, and then Tom, and then we'll see how we go in terms of a discussion. But if we do run out of time, these guys will be very happy to have you hunt them down over lunch and have a discussion. So anyway, Eric, welcome. Over to you.
Thank you. All right, there we are. It's on. Cool. I'll keep it very brief because we're meant to be having lunch at 12:45. So we'll see how quickly we can race through the slides. Fortunately, a lot of what I was otherwise going to be talking to has already been well covered in prior sessions. So one of the big things that we covered was that localism isn't just about councils, it can also be about ethnicity. So we went to Canada, where British Columbia has had the country's first and only First Nations Health Authority for the past decade. It is now into its second decade. They've secured a 10-year funding agreement for $8.2 billion over the coming decade for providing health services to registered status Indians in the province. So we want to see how that was working. NIB led the study tour. I was lucky to be included on it, perhaps to be doing some cultural translation between Canadianese and Kiwi in a couple of places that proved important, and I kind of sat in the background and chuckled. Might hit a bit of that. So the first Canada, very different. And I don't know how quickly we can go through the slides. We'll hit the first one if we might. Tino Rangatiratanga in Canada is very different from here. And I might as well grab that so I can just go along as we go. On reserves, Canadian First Nations have powers at least comparable to municipalities and councils here. And the health service provisions in treaties are much stronger than in New Zealand. You can read health services into Te Tiriti here. They're explicit from Treaty 6 onwards that Indians would be able to go to the Indian agent. It's archaic language is from the treaty that was over 100 years ago. Can go to the treaty agent and get access to the medicine chest in times of need. That has been read very broadly, and it amounts to a wide variety of services that are not funded for non-First Nations, non-status First Nations in Canada. The amount is substantial. Things that are provided through the Canada Health Act by provincial health insurance policies are still provided through the provincial health insurance policies, hospital services in particular. Those aren't, you don't allow any fee for service in Canada. Things that are otherwise provided to First Nations, that can be provided on a fee for service basis for others. The Canadian government funds it directly. In British Columbia, they shifted that at the request of First Nations to devolved authority. So rather than having the decisions made in Ottawa about the services that would be provided or under a slight amount of regionalization, it was coming down to the local community. They had a decade of that from 2013 onwards, and they're moving into their second decade. It took a long time to set up, in part because it's a much more heterogeneous community there than here. There's something on the order of 34 language groups that might be up on the slide. It'll be on the next slide. One of the neat things with devolution comes responsibility. I had liked Colleen Erickson's statement on that. And I might have already passed by it. All right. So Colleen Erickson had said, well, we can't just sit around and complain and pound the table. We're responsible for it. So that matters. But you've got 34 language groups rather than just different minor dialects on Te Reo. So that makes things a bit more difficult, and localist approaches matter a lot more when there's a lot more heterogeneity. So the approach was working to build up from local needs up through a centralized system in the First Nations Health Authority to decide what the priorities were going to be as set by those local communities, and then bring the services back down. They have had some successes in that. There's been some improvements in actual health outcomes, particularly around access to things like dental care. There was insanity in Canada where you had a billing system where dentists would have to go up to what had been called in my day the Department of Indian Affairs. It changed names 5 times after 2013, and I can't keep track of it. But they would have to go to billing basically to Ottawa. Delays in billing, complexity, messes meant that practitioners found it a nightmare to deal with First Nations patients who then experienced that difference as racism. Obviously, right? It was built into the structure of the system in addition to pre-existing racism in the Canadian system. Fixing that in partnership with Pacific Blue Cross seemed to really matter because Pacific Blue Cross was already dealing with all of these providers for other patients. FNHA partnered with Pacific Blue Cross, much better experience for everyone involved. They also were able to find local solutions around some particular kinds of bureaucratic complexities. You had weirdness in Canada where, as part of the funding deal, they were able to, it was nuts. If a First Nations band in a remote community you had access to dental care and they'd cover transport, it was more cost effective to have a local dentist than to ship every member of the band out to the nearest dentist, but they hadn't been doing it until they had this shift, which was like remarkable. Similarly, rules had that you had to get your service provided by the nearest practitioner, and like as a bird flies, might not be actually by transport. So you'd had people who were connecting in Victoria to go out to another small community rather than just staying in Victoria, because the closest one, as the crows fly, required a connecting flight, which was also insane, and they were able to stop some of that. They've got a great evaluation capacity. One bit that we didn't hear as much about, though, was harnessing those local approaches for learning. So they do have tremendous evaluation capabilities. I think they still have opportunities to learn from localism. And I think some of that is what's already going on here. So we have a lot of local devolution. We were already hearing about that. I don't want to go into it because, well, others have far more expertise in it, and Tom's already doing it too. we can build up from that and learn on the ground where it makes sense to collaborate with others, build regionally on that basis, and then build up from that rather than starting from a centralized authority and then working down. Because to me, subsidiarity isn't about pushing decisions down to the lowest level. It's starting from the lowest level and then discovering what problems cannot be solved at the local level and building collaboration at a broader level as you discover those areas. So it's a very different approach. I loved a lot of the discussion that the minister had. I don't like the idea that subsidiarity should be pushing down, because that has the default as being that it's held nationally. Really, it should be coming up the other way. I'll shut up and punt to Tom.
Hello there. Yeah, kia ora, Eric, and tēnā koutou. Listening today to a few very, very important people in our industry, Dr. Lester Levy or Professor Lester Levy, others who have got a big role ahead of them. They're talking about the same kind of things that we went up into Canada to learn. So I've, in recent meeting with my colleagues here to my right, we talked about in New Zealand probably needs to be looking at New Zealand solutions. You know, Dr. Rachel Brown from NHC, she said the same thing. We need to look inward and then work from there out. So I think about, and I like the idea from Professor Lester Levy, and it's decentralising, localising and devolution, but collectivising. And now collectivising is working together, supporting those around you that in the past you might think were competition because of the funding issue. If we take that funding issue away and we have a long-term view and forget about the difference in quantum you'll see between ourselves, I can't even calculate the figure, but we're about 6 or 10, maybe 10 times less per capita of available funds that was given to Te Aka Whātua, the Māori Health Authority in New Zealand, compared to the First Nations Health Authority up in British Columbia. Huge difference in numbers. Forgetting that, there is access for Māori, access for Samoan, access for Polynesian, access for those other communities. We have been working with NIB over the last 5 years, going overseas to try and find solutions, but the solutions are here with us. Toi Ora, a program that we will use to not just provide health insurance. Toi Ora is not about health insurance. Toi Ora is about taking away barriers to access to health. Tend with technology, telehealth they called it, but there's Tend as a brand. Those options that will be needed in the remote communities that some of our whānau live in, and including the minister down at Rangiora, a bit further north, have that story of having to travel to take a phone call to ring Wellington about an issue. Those things, those nonsense wastes of time need to be taken away. Collectivism is about us working together for the benefit of, and I loved what Professor Lester Levy said around the patient being at the centre of all our decisions that get made. I know Rob Campbell, a wonderful leader in the health area, and the statements you made got you in trouble, but no, I love the way you keep standing up for what's right, and that's what we need. We need people like you, and I look around the room, lots of people here who have influence. A lot of people I recognise. I'm happy to see some familiar faces. Once again, though, in a lot of these forums I go to, a little bit disappointed that I'm not one of the oldest people. That's it's normal. We need some young people. Innovation and health, innovation and anything we do in Aotearoa needs to include our younger generations, our rangatahi, our tamariki to a degree. We need that feed up to come from them. They are the future. If we can't convince them to be in the system with us, because the system will work for them to support the patient, our consumer, why wouldn't they? Why wouldn't they go overseas to a system that works better for them to help the people they want to help? So devolution, communities working together. For me, it does come down to also being collective, working in a kaupapa. People, place and purpose. He tangata, he takiwā, he kaupapa. People, place and purpose, working together for a common purpose is an old age thing. We can do that within the system. And I like the approach that I'm hearing from Professor Lester Levy, and I wish him all the best of luck. And he asked for help, and he needs help from people like ourselves, iwi, community groups who are doing the work, the PHOs, and there's a few in this room, the doctors, the nurses, the young people who are training. And we want them to stay. We want them to go and have an OE, but only for a few weeks. Come back home and work here. Ngāti Whātua are working hard on our Toi Ora program to make sure it's beneficial to the people who I'll say contribute to it. We currently cover our Mozzies, our Māori Australians, and we are thinking of reducing that benefit to a New Zealand only benefit, because potentially, as we look to the costs increasing, how do we get a premium offset from money that's available in the ministries, MSD, ACC, other areas in health, where we can say, hey, let's reduce our cover because we don't need that cover, because we know enough about our whānau, data, technology, that we don't need to cover Tom for a knee, because Tom is not just a Pākehī, but he's healthy, his BMI is okay. Let's stop covering the knee operation for him because he's unlikely to have it. And if he does need it, let's ensure that the system, because he's part of a system of toi ora that's reducing the numbers of people on the wait list, if he does, or one of the members does need that support, they get onto a priority list because they're not using the system as much as they were. So collectivism, user pays, but efficiency. And efficiency means ministries connecting the data, connecting the dots, and not wasting money.
I might just jump in with one last bit. One of the neat bits that we'd seen, they've got regional telehealth there that's operating 7 days a week. So lots of remote communities, difficulty in access. That's rolled out very broadly for First Nations. That was great. One slight provocation that I might throw in, and then I'll punt back to Rob. Their First Nations have authority for example, when the Squamish wanted to start building on their land adjacent to downtown Vancouver, they didn't need to ask anybody's permission. They could just start building, and the city of Vancouver said, you know what, we got something to learn from you because you're building a hell of a lot faster than we've ever been able to permit before. What would happen if, for example, an iwi found that they couldn't get a GP in a remote community and asserted a treaty right to say, you know what, this foreign trained GP that we get on with is perfectly fine. We don't need anybody else's permission. Why do we need that? I would love to, I have a lot of fun thinking about the implications of those kinds of challenges. Well, no, that would be the assurance would be on the iwi side, right? If it's someone in good standing with their college abroad who's come here and hasn't been able to get through the system that the New Zealand government has authorized, maybe there are alternatives.
I'm going to ask Tom and Eric a question in a minute, and it's basically, I'll give you an advance warning and then I'll give my answer to it first. But so what was the biggest kind of learning and maybe surprise for you coming out of the trip? But I spoke to Richard Jock, who's the CEO of First Nations Health Authority, on the last day that we were there, and I said to Richard, you've done so well, 10 years worth of funding and another 10 committed, billions of dollars. And I said to Richard, how did you do that? And he said to me, before we ever got any funding, we were doing it. That was the biggest learning for me. So sometimes you need funding, but sometimes you just got to do it first, and then you'll get the funding. So Eric, what was your biggest learning?
I was a little surprised at the extent to which, while the structure was thoroughly Indigenous and built up from what the communities wanted, it was also thoroughly very much a part of the Canadian health system and seemed constrained by some of that thinking. So for example, when Enid was discussing some of the work that she's been doing with her community and how they're just using iwi resources to fund health delivery, the Canadians were pretty shocked by that because it violates the accessibility requirements in the Canada Health Act, and also just seems anathema that anybody would be paying for their own services when it should be something that the government is doing. Man, you sit around and wait like that, you're going to have difficulty. Like, they were doing the work ahead, but not in the same kind of way. And I think that gives us some opportunities here.
Yeah, thank you, Rob. I think the main thing, and most of the other iwi reps who went, myself, George Reedy from Ngāti Porou, Enid Rātahi Pryor from Ngāti Awa, and Rangi Maria, who's supposed to be here, and I got subbed in. Her boss called her up this morning, so she called me up. She's still my boss. And if you know Rangi Maria, she said this, it seems like a big brown bureaucracy. So they've got a lot of money, $8 million Canadian over 10 years, 10 million New Zealand, 8 billion, sorry, billion. And that's for 180,000 people. And so they started creating within the system a few systems, a couple of boards, like another board. So it becomes a bit of a brown bureaucracy, and that's what we don't need to do here. We haven't got enough money here to do that. Wasting money is not what we can do, and I think collectivism is people contributing to kaupapa. And I'll say what Rangimāori said a year ago here. We made that decision to go down the track of better access to health ourselves. Mana motahaki, we pay a lot of money to do it, but it has changed lives. You'll see an article in the paper today that I think Rob was part of, and it talks about one person, but there's others. Not only saving lives through that approach, but having people talk about, hey, how can we work with them? How can we work with, I'll call it the veteran service, the return services here for people who, ex-Navy, Army, they're an older group of people that may want access to this as well. Let's work with them to create their version of Toyota. So collectivism is one thing, but no wasting money. And sometimes it does take bold people to make that step first, to show that they're a hand in, not just a handout for help. So let's try and work together. I know that a few of you will be involved in committees and so on going forth with this reform. We worry about reform as Māori because the reform and then reform of the reform and then the no form, it just wastes money that needs to be going to the communities. We did have a trial of what devolution looks like, and it was COVID. No one complained about how Māori communities, Māori and other communities close to the issue got involved, and they were given money. The money got spent wisely. The audits were a bit unfair after the fact, but when the Royal Commission for the COVID approach is finished, and Auckland had a hard time of it compared to other parts of New Zealand, you'll find that some people have said the approach by iwi, the approach by community was gold standard. So yeah, we've done it before, let's do it some more.
Thank you. And it was remiss of me, Rangimāori Hunia was due to speak. She does send her apologies. She's working in the Prime Minister's Department, and they changed the venue of the meeting to Wellington, so that's where she is today. But she will be here later on in the day as well. So I'm going to call it here. You've got a great travel log that Eric has written and to have a look at, and also please feel free to approach Eric and Tom over lunch. Eric, Tom, thank you very much for your time, and I'll hand to Chelsea or Michelle to give us some directions about lunch.
Oh, any questions?
Well then, we're open for questions. I was just thinking about a mental health break, right? You guys have been so good sitting there for hours. I'm going to take that as have 6 minutes mental health break and physical health break, and we'll see you back sharp in 45 minutes.